Welcome everyone to the June 2020 edition of the Prehospital Care Research Forum Journal Club podcast. As a reminder, the Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research, and we believe it's the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. And here at the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and today I'm joined by Dave Page and Dr. Tony Fernandez and Dr. Bill Toon. We're also excited to have with us a guest panelist, Jeff Rollman from UCLA. And it is my great pleasure to welcome the author of the paper we'll be reviewing all the way from Denmark, Tim Lindskou. Welcome, Tim, and thank you so much for being here with us to share your great work.
Thank you for the invitation.
As a reminder for the audience, the name of the article we're reviewing today is Predicting Outcome for Ambulance Patients with Dyspnea, a prospective cohort study. And this was published in JCEP Open, which is worth mentioning that JCEP Open is an open access journal. And if you haven't read the article yet, you can do so for free without institutional library access or anything like that right on their website. So as always, this discussion is paired with an article written by our very own columnist, Dr. Tony Fernandez in EMS World called Journal Watch. And we encourage the listeners to check out this article at emsworld.com under the category of education and training. Again, thank all of our panelists and our special guest author for joining us. As we're beginning, we want to remind listeners that you can always use the chat feature on your screen to type in questions, and we're going to bring those into the conversation as we go, so please don't be shy. And with that, let's go ahead and get started. Tim, thank you again for sharing your time with us. I want to congratulate you on this excellent work. And my understanding is that this work was actually part of your doctoral dissertation. So I really think double congratulations are in store, or maybe even triple.
Thank you very much.
So why don't you start off by telling us just a little bit about yourself and your background and interest in EMS and what your role's like now?
Yeah, sure. Well, I actually started as a nurse, which I worked as for some years. So I was primarily I believe it's called the outgoing nurse. So I drove around to people in the cities. And then after some time, I thought that, okay, maybe this is not for me, or maybe it is, but I would also like to do something else, and could I perhaps change some things? So I started by taking a master's degree for healthcare professionals that are here in Denmark. And then some time afterwards, there was established a research unit here in Denmark, or in Aalborg, northern part of Denmark, for the pre-hospital and emergency research. And I was employed in a position there, and somehow it ended up with a PhD now. And I really enjoyed it, and it's a very interesting field to be in. So I think I'm gonna stay here now.
That's a windy path that a couple of us know quite well.
Yeah.
But this is exciting. I think something that our audience members are naturally going to want to know a little bit more about is, could you tell us about this pre-hospital research center? And is it relatively new, or has this been established? What is your experience like with this EMS dedicated research center?
Well, this is a fairly new center, because there were, I'm sorry, I have forgotten, I believe it was 2015, or was it 14 that it was established. So to begin with, there was the pre-hospital professor, and then me, and then a student, and little by little it grew. So now we have lots of different professionals working with us, so statisticians and medical doctors, and again, I was a nurse. We had other nurses, physiotherapists. So we have grown a little, but still it's a very small and compact center. But then there's, of course, the benefit of Denmark also being a very small country. So we have 5 regions in Denmark, which each their own pre-hospital units. And we, of course, collaborate, and help each other, and try to do research together. So it's actually part of a larger network, although we are very few at our place.
That is so interesting and exciting to hear, how research center is being built from the ground up little by little, and that you have this incredible collaborative environment.
Yeah.
And I know that Jeff, who's on the call with us, had a question, generally just about the Danish EMS system. And so Jeff, do you want to go ahead and bring up that question about the setting where the study took place before we dive into methods and results, of course?
Sure. So thank you again, Tim, for joining us. I saw you had actually published a paper last year discussing the Danish EMS system, since unfortunately Google didn't have too much information. So thank you very much for putting that paper out there. I was a bit curious. I saw in the paper you had discussed that all ambulances are staffed by at least one paramedic, and there are two levels of EMS, it seems, paramedic and paramedic with special competencies in Denmark. Is that correct? And are you able to explain how that compares to the American EMS system workforce?
Yes, certainly, and a very good question, because it can be a little bit confusing. So currently now, as you said, we have two levels of ambulance personnel. So we have these paramedics and the paramedics with special competencies. And I guess we could somewhat compare the paramedics with your EMTs with a little more competencies. And then we have the paramedics with special competencies, which I think would be comparable to your paramedics. So these are the guys who can provide, more medications and, do some treatments in the ambulance. And they are also in some of the regions available in rapid response vehicles. So they are some of the first responders on scene. So these are currently the two levels we have.
Excellent. And
thank you for explaining.
Sorry, Jeff, go ahead.
Oh, I was just saying, thank you for explaining.
You're welcome.
And I want to piggyback on that a little, because I'm curious about how one pursues the career of becoming an EMS professional in Denmark. Do you know what the schooling is like, or what are the EMS education programs, where are they housed, and how do they work?
Oh, I'm gonna be very unpopular now if I say something wrong. So just as I recall it, I believe that.
Don't worry.
Yeah, because I'm of course not an ambulance professional. Took another approach by being a nurse. Yeah, but as I recall, there are of course some schooling you go to, and it is also intertwined, with practical stage, at the ambulance stations and so on. And I believe it is a 3-year education for the lower level, and then you have to be working as this paramedic for a number of years, and then you are eligible to train for being a paramedic with special competencies. And there has been some recent changes now in the educations for the ambulance professionals. So I believe that they're also now, what's it called? It is a protected title, and sorry, I'm at a loss of words at the moment. But there has been some changes to the education here recently, so it's been more qualified.
Yeah, no problem. That's very interesting as well. And here, there's also a lot of variation in the types of education programs. And we actually have a whole nother podcast dedicated just to educational research, because that's kind of its own world that we're also interested in.
Yeah, exactly.
And now I do want to, focus on this project at hand and talk just a little bit about what got you interested. So this project looked at the use of a pre-hospital dyspnea score, and what made you decide to take on this topic in particular?
Well, there is, I have to go back a little bit when we started with our research center, because, there have been other well-established centers, and, for instance, there are some, they focus very much on cardiac arrest, and, well, these guys, they focus very much on trauma. So we thought to ourselves, maybe not do the same as everyone else. So let's try to, actually, initially just see who are the ambulance patients, what is their medical condition like, and who are they? And what we found was, of course, there are many who have, for instance, cardiac arrest or trauma or something like that, but there are also a very large number who have breathing difficulties. and there's not so much research on these people. So there seems to be a tendency to think, okay, these are very unsexy patients to study. You know, are these the old ones? Do they have comorbidity? So it's not as popular, and therefore it was very obvious to look at this patient group, because we also know they have very poor outcome, and there are a lot of them. So it actually was, yeah, it was a very clear field to study for me.
I love this, and I know Dave Page will love this as well, trying to make research sexy for something that's common but doesn't get the attention. Awesome.
Yeah, and of course there are also other aspects of this. So you know, with mental disease, or with the patients who receive, you know, some of the non-specific diagnoses that are, you know, a mixed bag of everything. So there are a few of these unpopular groups that we would like to investigate a bit further.
The research orphans.
Yeah, yeah, we would call them that.
Perfect. All right, I am going to turn it over to Tony Fernandez to talk a little bit about methods, but first I want to see if there are any other questions from our panelists related to just background and general objective of the paper.
Mm-hmm.
I'm hearing nothing. All right, Dr. Fernandez, take us away and let's talk a little bit about these awesome methods.
I know this was you did some really good work, and I want to congratulate you again for not only finishing your PhD, but for getting this published. This is really great.
Thank you.
So let's dive in. We talked a little bit about EMS in your country, but what I'd really like to know, and what just I am so jealous of, is how you all are able to link data, and can you talk to us a little bit about how you obtained your study population and how you were able to get outcomes, because that is something that a lot of researchers in the United States would just salivate over.
Oh yeah, of course, and feel free to stop me if I go out in a wrong direction. But I completely understand what you said. I was at a conference, I think a year ago, where I met an Australian researcher, and I remember complaining to her that we only had, like, let's say 90% follow-up or something, and she said, stop, you're gonna make me cry, because okay, that was a little different than what she was used to. So understand,
Sure.
well, in Denmark there is an extensive amount of health-related registries, and there's just been a tradition for this historically, and it's not something that people really are concerned about. I know now there is a GDPR, which of course have changed things a little, but it's not something that people really think about or are against. So we have these very extensive registries, everything from, you know, smoking to cardiac arrest to cause of death, and there are many different registries. And then, of course, there is the civil registration number, which each Danish citizen has, and this is the unique identifier that is used throughout all of these registries. So we are able to identify on an individual level the patient and have all this data on them, and this also enables us to have this complete follow-up for the ambulance patients, for instance. So when they call the national emergency number, it is initially the police who answer the call, and if it is of a medical nature, they will then forward this call to an emergency medical coordination center, where we have some healthcare professionals who will then assess the situation and dispatch the appropriate response. And from this moment that the healthcare professional answers the call, well, then we have our patient, and these are also the patient group included in this study. So we know what was the cause for dispatching an ambulance, what was the measurement in the ambulance, because there's also a pre-hospital electronic medical record. So we also have information from here. And then, of course, if they were brought to a hospital, well, we have the diagnosis they received, and we have, again, from the civil registration number, we know, well, did that patient have a date of death? Because, okay, then we can also calculate the mortality. So I guess we are a little spoiled in this way, that we have all this data available.
Just a little bit, and certainly I'm certainly jealous. But yeah, and you get to use it for great work like this, which is really a cool experience, I'm sure. So you looked at patients from July 1st, 2017 to September 14th, 2019, and you looked at all all patients who were 18 years of older with acute dyspnea as their main symptom.
Yeah.
And you implemented an intervention, which I think a lot of times we overthink these interventions. What I really like about yours is it's easy to use, it's simple and sweet. So can you talk to us about how you came up with your intervention and how it was utilized in your study?
Yeah, of course, it's not very novel to ask a patient, can you rate something on a scale from 0 to 10? But perhaps in this context, I can see that it's a bit new. So of course, it was something that was readily available, you know, this rating scale. And there are a lot of tools available to assess patients' subjective experience of dyspnea. But as you might know, of course, there are some who are several pages of questionnaires, you know, and some can only be used perhaps months or weeks after the patient had their initial dyspnea. So this was something, as you say, it was small and sweet, yeah, can be used here and now. And it's something that the ambulance professionals already are familiar with, because it is the same way that they rate pain in the ambulance. And they do this very routinely, so it's also easy for them to use. And then I believe the second part of your question was the implementation. And again, we have this pre-hospital medical record, which is now actually the same pre-hospital medical record in the entire country, which is also very nice when we want to do a nationwide research. But I digress. We have developed a research module in this medical record, so we can you know, implement these very small things. And this is very simple, of course, you know, scale from 0 to 10. It does not take much programming to implement it, but still it was possible. And then of course we don't need to have any paper trails or something like that that would disturb the treatment in the ambulance, because of course these patients also received their normal treatment, and this, you know, rating from 0 to 10, it was just a bonus if there was time or if the patient was not in an acute situation, you know.
Excellent. And you were able to get buy-in throughout the country to implement this into their assessment. Is that correct?
No, here at the moment we have only implemented here in the North Denmark region. But again, okay, you can, yeah, as a concept, yeah, it's able to roll out nationwide now.
Well, that's super interesting. So could you tell us a little bit about that research module in the electronic patient care record? What's the process like for requesting your variable to be added to that module?
Oh, I don't think there is any established process for it at the moment now, because again, it's still fairly new. We have had this electronic medical record in the North Denmark region since 2006. And again, it's only been nationwide since 2015, and there's still, you know, some kinks to work out, and you know, we all have to agree what we would like to do. But I believe it's on a regional level. You are able as a researcher to, you know, come with a request and say, well, I would like to implement this, and it is sufficiently simple, and I believe that it can be implemented here. And then each region are allowed to know, determine, okay, we want to implement this.
Well, that's fantastic and opens up a lot of really great opportunity.
Yeah, it certainly does. Yeah. And I know there has been a few additions now since it has been added. So that's very interesting.
Right. And we talk a lot on this podcast about, you know, our national EMS data standard is called NEMSIS here. So each software can collect the data elements in a different way, but they must get mapped back to a core set of standard data elements. And it sounds to me like in Denmark, this problem maybe doesn't exist because you're all using the same piece of software. Is that correct?
Well, now we do, yes. And I believe that it is nearing completion, yes, with interpreting the data the same way, because of course, you know, it lies on some servers when, you know, everything that is entered in this pre-hospital medical record, and you have to extract the data. And perhaps they are a little bit, what you would call it, they are not necessarily in a very easy to read format to start with. So I know there is a nationwide project now where we try to you know, organize it so we agree, okay, when we pull pre-hospital data, we do it in this same way, and we interpret this as a pathway for this patient when we have to identify them all the way through the healthcare system. So we do it the exactly same way. And I think that is, if not done, it is very near completion. So again, enabling this nationwide research by all doing it the exact same way. So that's very, again, it's a bit unique, but we're very happy about it.
And we're very jealous.
Yes, and now we get to talk about the parts that'll make us most jealous. Speaking for the researchers and the budding researchers on the call. So let's talk about your outcomes. You were able to, your primary outcome measure was hospitalization for 2 days or more following the ambulance run. And then you also had secondary outcomes, which were admittance to an ICU within 48 hours and 30-day mortality. Can you talk to us a little bit about why you chose those outcomes, and and again, a little bit about the availability of those outcomes in the data set?
Well, we chose these 3 outcomes because we really wanted to look at, the short-term outcomes where, the entire goal of this that would be fantastic if we could do was, could this scale say something already, in the ambulance that made us change perhaps the treatment or our, urgency level? Should you put on, lights and sirens instead of not, and get the patients in beforehand? So something where we can really do something to change the outcome for these patients. So therefore, we really wanted to focus on these short-term outcome instead of saying 1-year mortality or something like that. So that was really the reasoning behind this. And again, the availability, well, again, I can only say that there are the national registries where again, all this data are available. So we just linked it up again with the patient's civil registration number, and we had this information available to us.
Now, as a point of curiosity, you're able to access this kind of information through the civil patient registry. I'm curious, do the EMS professionals have the opportunity to see their outcomes for patients? I know later in the paper, some ICD-10 codes and ultimate diagnoses are presented, but is that something that the field provider can generally gain access to?
No, they do not have any of this information available, and not also includes the patient's, previous diagnosis, or if they are, and this is also not available to them in the ambulance, no.
Interesting. Something that we always talk about, is closing the loop on this feedback and how can we do a better job at it. It's certainly a challenge that we face here as well, and working on ideas for how to make that a more continuous process. And what you just said was really important too. What about their previous diagnoses? It would be so helpful to be able to
is there any known conditions or something? Yeah.
Exactly, or allergies even, and things like that. So yes.
Well, again, just to get specific, I believe there is a separate system for this. So, if there is any allergies, it will, however, pop up. But again, not previous diagnosis.
Excellent nuance.
Yeah.
Yes.
Very interesting. Now, we on this podcast, we talk about relatively often logistic regression and how you deal with dichotomous outcomes. But one of the things that I really liked about what you did and your paper and your analysis plan was that you split up your data set and into training and validation sets with randomization. And so keeping in mind that a lot of our audience are budding researchers, and can you give us some explanation of how you came about choosing this analysis plan, and then how you ran the training and validation analyses?
Yeah, I can certainly try. Well, of course, there was something we discussed in the author group. How should we try to predict the patient's outcome? And there is this very classical approach where, of course, we could just see, the results, how many patients were actually admitted, how many were not. But if we want to try to assess, well, what if we would like to try to use this model on, future patients, not just make it fit perfectly on the ones we have. This has to be able to be used on other new patients. Otherwise, there's no point to it. And therefore, you know, traditionally you can take all the data you have and divide it, as you say, into some of the part of the data used to train this model here, and then you test it on the remaining part to see, oh, okay, could it actually predict anything?
And can you tell, I'm sorry to interrupt, can you tease out what you mean a little bit by train the model?
Yeah, exactly. Well, this is some, you know, statistical mumbo jumbo, but you know, basically it's just we want to say, okay, if we, in case of this article, let's say we wanted to see if is a patient, do we believe they're going to have a stay at an ICU, and we'd like to see, okay, if we include like age, sex, and this dyspnea score, could we somehow predict using these items that the patient would be admitted? So some kind of combination of these things, could they say anything about the patient's outcome? And this is what you train this model for. So does that answer your questions?
I think so.
I like the statistics mumbo jumbo personally, but for those who may be having their ears glass over right now, or whatever ears do when they want to listen, I think a picture is worth 1,000 words. And so we are displaying on the screen right now, but for those who may be listening later, figure 1 does a really great job at showing the distinct steps in this process. So thank you for including that great figure.
Yeah, thank you. It was just as much for my benefit, so I could remember it. So. But yeah, and this of course also illustrates that of course we could not be satisfied with just doing this once, so we actually did this 5 times using all parts of the data, both to train and then to validate, that is, you know, try to see if it could predict anything, just to really force it through.
Absolutely. No, I think that was great. And Jeff, did you have any other questions about the methods after the validation?
Sure, yeah. So first of all, yeah, thank you again for including that figure. This is something, of course, we use logistic regression very often, but it's great to see kind of the next step applied to machine learning here. So I'm not sure if we're able to move on just to some of the ROC and AUC curves. So we can take a quick look and see kind of the outcome of this. I was wondering if you could explain what those numbers were, those results, the area under the curve and the receiver operating characteristic.
Yeah. Yes, and this is also a bit, again, let's say mumbo jumbo once again, but this is the result of our analysis we did here with the logistic regression. And the way we present this and have done in this article is by drawing these curves on a graph. And what it really illustrates is the sensitivity and the specificity of these models that we try to train to develop to predict the patient's outcome. And what that really means is what is the probability of this test, saying that, let's take again ICU as an example, what is the probability that the model said the patient was admitted to an ICU and that he in reality was, and also what, you know, if the model said the patient was not admitted to an ICU and in reality he was not. So of course we want to get both a high sensitivity and a high specificity, so it's able to correctly identify those who had the outcome and those who did not. So that's actually the goal, and that is what those graphs actually illustrate. That is how close do we approach this perfect end result.
I think that's a really useful explanation of this, and it's something that is very commonly encountered in research, so I'm glad we got to spend a couple of minutes talking about it. This concept of receiver operating curve and the ability to discriminate between a patient who has an outcome and who doesn't have an outcome. And then, you know, something just for the audience to help put this in perspective too is that a 0.5 under the curve is like a coin flip. That means that this scale, whether it be a stroke scale or a dyspnea scale or whatever it is we're looking at, is no better than a coin flip at prediction. And then the closer we get to 1, the better we are. And 1 is perfect prediction, says this thing knows exactly who has what.
Exactly, so yes.
We'll definitely take a look at those figures as we get into the results, but I'm thankful for your explanation that we got to spend a little bit of time just explaining, you know, why this kind of methodology is really important.
Absolutely. So I think I've geeked out enough on the methods here. If none of the other panelists have any questions about the methods, I think we're ready to talk some results.
The most exciting part. Okay, so everybody who shut their ears, open them back up because here we go.
Yeah.
The mumbo jumbo is done. All right. Well, let's start off with
find some more.
I like the word mumbo jumbo. I'm going to start using it exclusively. Let's talk a little bit about just the study population and who ended up included. So you had over 3,000 ambulance runs included in this study. Do you want to talk to us a little bit about the characteristics of these patients? Was it what you expected, essentially?
Yeah, it actually is. You know, looking at our previous research, they very much correspond to the patients that we expect, and I'm sure you're here referring to, of course, the age of the patients.
Yep, absolutely.
Yeah, so of course there are many among the elderly who have breathing difficulties, and we also have to remember that, of course, breathing difficulty is a symptom in many underlying causes, you know, so it's very prevalent in a lot of different things. And of course, again, the elderly is most prominently here, but you know, it covered all age groups. So again, we set the limit at the age of 18, and there are of course also some who were, you know, 18, 19, 20, and in the younger groups. But yeah, no surprise that the majority were elderly.
Yep, I think that the average age was something like 70 and about half female, half male, which seems to be in line with what we might expect for this population, right?
Yeah, exactly.
And so let's go ahead and take a look at our next table. And you can just walk through some of these characteristics. In table 2, in addition to age and sex of the patients, you talk a little bit about the outcome of the ambulance run, and the vast majority of these patients that had a dispatch complaint for some sort of dyspnea or breathing trouble were actually brought to the hospital. So that was 96% of them.
Yeah.
And then only 1% ended up released on scene. And you talked about in this case, the dyspnea score was evaluated for both those who were transported and not transported. Is that correct?
Sorry, come again?
So that the dyspnea score, the EMS professional did record that even for those who were treated and released.
Oh yeah, they did. Yeah, we have instructed the ambulance professionals to include any patient where they assess the patient as having breathing difficulty at the main issue, and this is regardless whether they are treated or released on scene, brought to hospital, or another option. So yeah, they were also included. That's why they are present here in the table.
Perfect. And then the next part of this table, which it's really just a long table too, but I broke it here so we could read it on tiny slides. But for the audience who's listening, table 2. When we take a look at some of the diagnoses that were given in the hospital, you know, are these things, this is a really good way of gut checking and saying, are these what we would expect for patients that had dispatches related to dyspnea? And so do you want to walk us through just a little bit about the types of diagnoses these patients had at the hospital?
Yes, well, again, they correspond very well to previous research we have done for this specific group of patients. So of course there is majority ends up receiving a diagnosis within the respiratory diseases ICD-10 main chapter at the hospital. And then they are rapidly followed by those who receive a diagnosis within the circulatory diseases, and then followed by the 2 non-specific diagnostic chapters. And this is something that we also very much expected.
Absolutely. And I think having this outcome data really allows for that loop closure and to ensure that what we expected, it looks like the population that we know. So past gut check is what I always look for.
Yeah, okay.
And then as far as your outcomes, you know, something we talk about on this podcast a lot is whether or not the sample size was appropriate for the kinds of modeling. And this is something that you all clearly put a lot of thought into as you selected your variables for the models and reduced the number of variables in the model to be sure that you had enough events.
Exactly.
So for hospitalization, you had about 2/3 of the patients were actually hospitalized for 2 or more days, which was the first outcome. And then when we talk about ICU within 48 hours, that was 5%. And then when we talk about the 30-day mortality, almost 10%, 9%. And so that allows us to go ahead and move into these models. So let's dive into the good results. Looking at table 3, talking about some of the outcomes in the modeling. Do you want to walk us through, or you don't even have to look at the tables, but tell us what some of your major findings were, or what should the key takeaways be for our audience here?
Yeah, I think that would be a little easier because again, we were, you mentioned it very briefly before, the way we report these results are as this AUC, the areas under the curve. And again, as you remember, if it is 0.5, we might as well flip a coin. But then again, and 1 is perfect, but then it's very difficult to say, okay, is 0.6, 0.7, is that good? Is that bad? And so it requires a little bit of interpretation. But what we found, if we'll start at the lower end, actually, I think would be the most interesting thing is because if we try to use just our dyspnea score that we implemented to see, okay, what was the area of curve for the dyspnea score when we wanted to see if a patient were hospitalized for 2 or more days, and it had as AUC that was very close to this flip a coin line, which, okay, let's say that's perhaps not so interesting because it would be much more interesting if it had a very high AUC and say, oh, this is perfect, let's just use that and we can see what happens to the patient. But that's not how real life is, of course. What's interesting is if we look at some of the other things, because then we said, okay, let's check for instance, blood pressure. Let's check for oxygen saturation. How do these perform when we want to predict the outcome? And what we actually found for most of them was, okay, they did not perform very good either. So it was not that the dyspnea score necessarily was bad, but it was not worse than the existing measurements. And that's very interesting because we always believe that, for instance, number of breaths per minute is very important for the patient's outcome, and say, okay, this is the most, what do we call it, the outcome that says the most, the parameter that says the most about the patient's outcome. Always remember, respiratory rate, the oxygen saturation. So that was an interesting result that neither of these performed very well either. And then, of course, we said, okay, let's try and use them all together and combine all of them. And then we actually had an improvement. The AUC actually got up about 0.7, which is, okay, maybe now it tells us a little bit more. So this was the interesting part here when we try to combine them, and this really shows that, okay, there is a point to combined triage systems, scoring systems.
Absolutely, and I think something that's worth highlighting in this approach is the humility of the authors to look at each step like this and then to remove the dyspnea score. So this avoids that confirmation bias, because you say, well, we have to see if we take out what we're interested in, does this still work?
Exactly, yeah.
Yeah, and I'll open it up to the other panelists. Does anyone else want to chime in with a question before I move into nerding out a little more on these AUCs?
I think I was going to jump in, Remley. I'm really happy to see this, especially this combination about all variables and all variables removing these scores. So I'll admit that trying to calculate, whatever it is, GCS, ABCAR, burn, whatever the LA stroke scale is today, you feel like you're trying to have your brain take all these variables and turn them into a number.
Yeah.
And I think that when we use, respiratory rate, SATs, if it's sort of like these are measurements that we're routinely, able to get and with the help of a computerized chart or one of the devices in the ambulance, we could have this sense of, okay, the scale is helping us figure out Are we getting better or worse? And is that the right interpretation? Are we seeing, can as that then change over the course of our care, that number become a better predictor of, look, we've done some care, things are improving, and now we're predicting lesser hospitalization up to 30 days was, I think, your outcome. So.
Yeah, well, that would, I think that would be the gold standard to say that we could implement it in this way, and that perhaps the results actually suggest this, especially for the combined variables where we see this higher area under the curve. And it is also something that is to some degree already done in the ambulances. At least in Denmark, there are some different scoring system and triage systems that are implemented. So, and then it's color coded. Oh, okay, this is red because now these and these values have been, summed up and calculated by the pre-hospital medical records. We know, okay, this is serious. So this is just really a naive approach towards the same, and we can say just try to take each single variable that we include in this study and see, well, could this have any effect on this combined score in any way? So what you said is very correct. Yeah, it could actually be something that you say, if we see a reduction in this score, okay, maybe the patient has improved and it is not as urgent as it was before regarding these outcomes.
It's fascinating to me that your approach is similar to another paper we reviewed long ago. Vic Convertino has written about this shock index. And the concept again is to put all of these measurements, this blood pressure, pulse, respiration, and in his case, an arterial, captured from a pulse oximeter-like device, the arterial pressure and variation in the area under the curve when we take a breath, the effect of pressure in the chest. And so improvement on circulation. And so putting all of these things into an algorithm that's a self-learning algorithm, a bit like the vacuum cleaners in your home that are learning where the furniture is when they automatically, so they don't keep banging into your furniture. They know, okay, I've now learned this is working and this is not. And having a better dynamic prediction based on real-time information. So how that prediction changes, whether it's because of the patient's physiological response to their illness or because of our intervention, really could guide care as we see patients worsen or improve. And that it might also improve if we add items like non-invasive and tidal CO2. Did you guys think about adding that in with the measurements, or is that a measurement you routinely get as the ETCO2 expired?
We do not, it is not as routinely collected as the other measurements we included here. But yeah, it would be obvious also to include this, and for that case, all the available information we have. But we wanted to keep it simple here as a start with, with the most routinely collected and variables.
Love it, love it.
And just a quick to expand on what you said, that yes, it's very interesting, could we have this dynamically developing score? And I think we of course all agree and we all know it, but just like to emphasize again, yes, it would be excellent to have this, to support the ambulance professionals, because those are the ones who are seeing and treating the patients. So their expertise is, alpha omega in this case. So because we also need to, acknowledge and remember this expertise that is in play here, but of course they also need the tools to support them. And one of the interesting things is also when we included this dyspnea score, also just to what should we call it? I've been told not to be so humble in this presentation today, so I have to talk things up again. And specifically with the dyspnea score, one of the interesting things we saw in that were if you looked at it just raw, well, the initial score of the patient, it was very, very high score that they all rated, so a median of 8 when they were first made by these ambulance patients. And then immediately before arriving at the hospital or released at scene, they had actually a decrease in the score, so it was closer to a median of 4. So something is really, really happening in the ambulances during this pre-hospital treatment that helps these patients very much, regardless of the score or not. But now we just have, you know, a measurement of it that we can see that, okay, subjectively, this patient is feeling much better now.
And you have hit the point that I absolutely love about this paper, and we don't want you to be humble. We definitely want to brag on this finding.
Yeah.
I think that, you know, perhaps the hypothesis going in was centered on whether or not this scale is a good predictor of something, and it turns out maybe the results weren't there to say that this scale alone can be a great predictor of patient outcome, but
Exactly.
the finding that it could be used to measure pre-hospital performance or the value of the pre-hospital care during that ambulance ride is super important.
Exactly. Yeah. Yeah.
And it's a really simple score, very, like you mentioned early in the introduction of the podcast, that, you know, we're very used to saying, what's your pain on a scale of 1 to 10? How much different is it to say, how difficult is your breathing on this scale from 0 to 10?
Exactly.
I think there's a lot of possibility and, you know, low barriers to entry, right?
Yeah, exactly. And it would be, you know, unthinkable now not to ask a patient, you know, how would you rate your pain? Because why would you not ask them that? That would be crazy. And again, why not perhaps routinely, you know, if you're having breathing difficulties, try to get a similar score on these patients.
Absolutely. Were you able to get any feedback from the field on this score? Was there resistance to using it or anything like that? Or do you think it will be continued to be used in the future?
It's currently still running here in the region, the score, and we have a very close collaboration, you know, with the emergency medical services here in the North Denmark region, who has also been an excellent help in this project and in implementing the scores. And we also, one of the co-authors is from there. So we had this very close contact with them. And then also the ambulance provider that is a private contractor in the region. We also had, you know, close contact to them. So I've been out on several of the stations, you know, and promoted this. And, you know, in the newsletters, we have also made, you know, little updates and look how many you have registered now, look what the scores is, and, you know, trying to include as much as you could in each step. And of course, then I've also been, you know, on what do you call them? Ride-alongs, I think, you know, so I've been present in the ambulances just to both observe and interview the patients. And there I also had some informal interviews, you know, with the ambulance professionals. And we also talked about this score, you know, and they seem very, very open to using it. And of course, there's been some, you know, implementation period where perhaps there was not as many scores registered as we would expect. But this is, you know, this is very common for all new things that you implement. And to begin with, it was located in another part in the pre-hospital electronic medical record, so where it was hidden a little bit, and that of course doesn't make things any easier, but they have been very good at using it and seem to not, well, at least not have anything against it.
Love it.
Hey,
Any
this is
other
Bill
questions?
Toon. Yes.
Oh, go ahead.
So how did you provide, first of all, before I forget, excellent paper, I'm enjoying it greatly, and the discussion. How did you prepare the providers for the study? What knowledge or information was passed on to the providers before you started collecting the information, or is everything done behind the work in the by the device itself, the data collection?
Yeah, I certainly hope that we did not really jump anything on them. You know, we use what do we call them? You know, something in the form of, you know, standard operating procedures that are available for the ambulance professionals, so they know, okay, you have a patient with breathing difficulties, do this and this. You need to give intravenous medicine, do this and this. You know, all these instructions, and we made one and sent beforehand to the project to these ambulance professionals, so they had the instruction for the use of it before it was implemented. We also carried out a pilot study in a small part of a region just to test out how would they actually receive it. So these were perhaps more prepared than their colleagues. And then finally, we have, on regular intervals, they have, what do we call it? For lack of a better word, teaching to keep the skills up. And we attended some of these sessions where we also, talked in general about our previous research, but also introduced them to, okay, there's going to be this new scoring system here.
Excellent. And one follow-up question. Was there any effort now or in the future to take in the provider's gestalt about the severity?
So again, you say gestalt?
Well, meaning in the sense their gut feeling, their experience and their knowledge about, hey, yeah. I really feel that this person, even though the score is a 4, I really think they're a 10 or something, where they put their impression on top of that.
Yeah, that's it's a very common question that's come up in this process. So first off, very important to remember, it's a completely subjective experience to have, dyspnea and breathing difficulties. So there is not really any way that the professionals are able to assess it. And I know from previous studies that have done so, when you have a healthcare provider trying to assess a patient's intensity of pain, and then you ask the patient themselves, well, they never add up because healthcare professionals tend to underestimate it. But it's a very good question, and from some of these informal interviews I had with some of the ambulance professionals, actually the only one who mentioned anything regarding to it was that, okay, he was surprised that a patient did not have a decrease in his score after he had received medication, and he would not really have thought that otherwise, and then he could, act upon that. So that was, kind of a praise, but perhaps there are some out there who haven't had the guts to come up and tell it to my face yet, but I'll have to ask them.
Thank you.
Excellent. Other questions from our panelists? We have time for a couple more.
One more thing I wanted to bring up before we go too deep into AUC and ROC is some of the patients who couldn't use the scale. Some of these patients that had, such severe dyspnea that they weren't able to give a rating. And those patients, of course, were excluded. But I know you found some very significant findings of those patients. So if you wouldn't mind just explaining briefly about those excluded patients and what you found. I found it really fascinating.
Yeah. And that's we added an option for the ambulance professional that they could rate the patients as unable to use the score if it was an acute medical situation, and also they could also rate them unable to use the score if they for all other reasons. So if there were language barriers or something like that. So of course those patients unable to use it were not included in this area under the curve part of the study, but we did a separate analysis on them where we tried to investigate what are the odds of these patients having an ICU stay, having mortality, and perhaps not so surprising again, when the patients were unable to provide a dyspnea score due to an acute medical situation, they had very, very poor outcome compared to the other patients. And then that again could also be, that's something that could be used here and now. Okay, you are unable to provide an answer, then we know this is serious.
Absolutely. I think that's a critically important finding. And again, kudos to the authors, not only for evaluating their study question and just the variables that were in the study, but taking a look at even the excluded patients and some of the rationale behind that. I think that could work for a lot of the scales. We do like a stroke scale, right? If the patient is not able to complete a stroke scale, it's possible that they're sicker than the patient who can.
Yeah.
Wonderful. Now we're in the last 5 minutes, so I do want to open it to panelists for the last comments, and the time really has flown by. So again, just want to say how much we appreciate this. I will go ahead and go around the panelists. Bill Toon, any last words, comments, last question?
again, thank you very much for the paper and being here with us today. What is your hope for the future? What's next? What's the follow-on to this?
Oh, that's a great question, because now we've done, a series of different research on this patient groups, and what we found is not very surprising, because we have confirmed that yes, this is a large patient group and they have very poor outcome. And then we have, discovered some new things, this novel approach using this dyspnea scale, for instance. So of course, the next obvious step that would be very nice if it was possible was, could we somehow improve the patient care outcome? So for instance, if there's a patient with, cardiac arrest or an embolism, there is a very clear procedure what needs to be done. There is a, what should we call it? There's a package deal that gets activated very, very quickly. So could we do something in a similar way for the patients with dyspnea? So we know, okay, could we do something already in the pre-hospital state? And if not there, then at least, have some some standard procedures at the emergency department just to improve these patients. So we, in general, just have a better focus on them and try to improve their outcome, regardless at what level it is at. It could also very well, be even before we get to at a pre-hospital state, at the patient's own home or somewhere else. So I think that would be the next step. Try to find out what can we specifically do and how do we implement it.
Love it. I love the answer. I'll jump in. Bill, I think you took my question away, because I think the same thing. So where do we go from here, kind of thing? And this higher AUC predictive, 0.73 is impressive. We start to see, as Remle put it so beautifully and simply, when you make statistics sexy, then the mojo is working, right? The mumbo jumbo gets sexy. So if we can get closer to 1, we can get scales and tools that are kind of helping guide our care, then in real time, those decisions help us, change our methodologies. But I'm hopeful that you're going to succeed, because I'd love to, not just take this model with I like simple is better. Simple is straightforward. I also tend to get, large amounts of data when I'm looking at the end-tidal CO2 or other signs of perfusion. And could we then incorporate these into a future care? So I'm excited to see you continue this work, and I hope you do.
Yeah, thank you. And I also hope so.
We'll have you back on.
Yeah, that would be great. Perhaps you can come and play with us and join the studies.
Now you're talking.
Absolutely. The podcast will be from Copenhagen next week. Let's go.
Super.
Jeff, well, first of all, Jeff, I want to thank you again for being a guest panelist with us. And do you have any parting words or last question?
No, thank you so much. This was great to have you, and definitely great to see what's happening in Danish EMS. And as we discussed earlier, very simple intervention, but very interesting results, and definitely interested in seeing what happens next and what the future research is on this. So thank you for sharing your excellent work.
Oh, thank you very much.
And Tony, last words, last comment.
Just again, congratulations, great study. I really appreciate your time being with us to explain this, and yeah, congratulations on finishing your PhD.
Thank you.
Yep, and I will get to wrap us up, and I really would like to close one more time by commending you and your co-authors on this project and the publication. I know that boiling a dissertation down to a manuscript is quite an effort, so thank you for taking that on. I also want to thank you for making it freely available through an open access journal, so EMS professionals worldwide are able to access this. And most of all, Thank you for sharing your time here with us today. This is a huge deal to us, and we really appreciate you being on. We know it's later in the evening for you, and thank you for taking the time.
Well, again, thank you very much for the invitation, and this was great and a very nice initiative. So I certainly hope that this inspires some new pre-hospital researchers.
Absolutely, especially if there's promise of trips to Denmark. I think we've got it.
Oh, excellent.
Okay, with that, I'm going to wrap us up. So I want to remind everyone to join us for the education version of the research podcast later this month. That will be on Friday, June 26th at 10 Pacific, noon Central. And we will be back here with our clinical podcast, as always, on the second Monday of the month, which happens to be July 13th. Thank you, everyone, for listening, and we look forward to being here with you next time.